So here's just a case there, we're part of a case anyway. We're going to build these up. You can see there, it's not even, but it's sort of relatively what I want. They're just composites, they're not particularly fancy. I don't do tons of fancy composites. I know some people do, and again I'll show you some in a minute. But we can build these up, which opens the vertical dimension at the back, allows this to occlude reasonably well against the anteriors, which is still to come. And that's all I'm interested in. And then you play one against the other, top against bottom, I mean. And you have a look at this case. So we've got a lot more even occlusal plane at the back. We've opened it up heaps. You can then do, I mean, that's coming out. We can restore these with you know, implants, bridge work, partial, whatever. The idea is you try and flatten out the posterior occlusal plane in a nutshell. I've talked about this, what height. You get the longest incisor. You still have to assess the anterior occlusion. Now we'd be doing these together, okay? You wouldn't just build these up. I'd be, you know, extracting, prepping, crown lengthening, which if we do in this case, that to marry that to that. And some of that will be based on a wax up. Oh, here we go, assess wax up. And the other thing is, remember one big advantage of opening this vertical, and some of these things I'll say twice, and I'll say it the first time now. The advantage of opening the vertical dimension there is sort of several. You may be able to improve the aesthetics because they can show more teeth. I'm talking about, say, uppers more than lowers. You have a more even incisal plane and more even occlusion. I wouldn't like to have to make crowns against these jagged edges on the top, so you'd improve that by doing that, and you'd even up the occlusal plane posteriorly. What I mean by that is often on the posteriors you've got, you know, several teeth missing, tipped, over, erupted, etc. So if you've got a tooth that's hanging down for an upper or hanging up, if you like, for a lower, if you open up that vertical dimension, that flattens out that occlusal plane drastically. So that makes things a lot better in terms of that. Plus, what happens is, you know, it just means that you're going to have a lot less tooth reduction if you're doing a crown prep. Because if you open up a mil or two or three between the upper and lower arch, that means you've already got a mil or two or three of occlusal clearance. So you don't need your occlusal crown prepping because you've already done that by opening the vertical. And that's a big plus in teeth that are worn so much that they get to the point where you can't take any more off because you're going to be hitting the pulp. So we aim to improve the aesthetics to some degree, incisal plane. The other big thing the patients love, and tell you that from experience, is to get rid of those brown areas. To them that's a great improvement, and you even out the posterior plane. So they've got some huge advantages doing that. There's some disadvantages too. It's coming up, but I'll tell you now. When we do this, okay, when we build those up, there's a few things I tell the patients. One of which is they've got a higher maintenance. You know, if you're doing crowns on those, they're probably going to be a lower maintenance. You've got these composites that are going to be chipping, wearing, and you know, so you're going to have to maintain it and maybe rebuild it. So one thing is they're going to have a higher maintenance. But the cost of this compared to a crown, you could do for 6 composites, for one crown you could do 6 composites, let's say. So, you know, the maintenance, you just have to tell them that. There's some other implications. The other implication is, and this is really, really important, it's coming up, but I'm going to tell you now because I'm having a real touch of verbal diarrhea. And what happens is, I've had a few of these where we did this 10 or 15 years ago. And these composites have slowly worn over 10 or 15 years. And so they've worn down to half their length, or down to the tooth structure. And what happens then is a bit of brown shows through again, or a bit of composite chips off, or the whole of what's left of the composite chips off. The patient comes in and says, well, I just want a new composite on that one central. You say, you can't do it. The reason you can't do it is as it's worn, and then finally chipped, it's over or continually erupted. So you now got contact between the incisal edge of the lower against the palatal surface of the upper. So you can't rebuild just that one unless you rebuild and increase the occlusion for all of them. And they don't understand that. I'm just telling you as a fact. They don't understand why. You did it once 10 years ago, why can't you build that one up again 10 years later? And you can't. I know that's happened to me a couple of times. So there's a couple of issues in terms of building up mandibular anteriors I'll mention. One's the VDO, vertical dimension occlusion. And if you're going to build these up and work on the front, one take-home message is you have to have good posterior occlusal support. If you start mucking around putting crowns on these or building them up in composite or ceramic veneers or any other thing, if you don't have good posterior support, these things are not going to last very well, okay? The other thing, which I haven't got there, but I'll tell you now, if you've got a class 2 Div 2 occlusion with a great, deep bite, that in itself is not really that. If you've got full arches, that really is not necessarily such a big problem. We say you've got to have ortho. Well, not necessarily. Where that becomes a problem with the class 2 Div 2 is when you start losing posterior teeth. Then you've got your lateral movement and the deep bite, and that plays hell with the anteriors. Once you've got posterior teeth, that's not so bad. It's not too bad at all. So I think it's the same case actually, and we've built these up with composite and we've got posterior support in terms of implants, okay? The other big take-home message is I wouldn't do this until the implants were in. Now, when I say the implants are in, I don't mean these are restored, unless maybe they're restored with temporary crowns, implant supported crowns. But what we'd do here is we'd place the implants, and again I don't place implants, I have a surgeon does it. So I say the royal we would place implants there and make sure they integrate and make sure if there's any other teeth coming out, they come out, and then I wouldn't touch these until the implants have been there 2-3 months. And then what I would do is restore these and go straight after the implants at the back. And we'll talk about full arch restorations just after the break, I think. There's several ways you can do it. Some people do the back first, then the front. Some do the top, then the lower. Some do the lower, then the top, etc. And I'll show you how I do it, okay? But certainly, to give you a hint there, we'd make sure that these are almost pretty well ready to go. And then that would mean these will be built up, and very, very soon after, we'd restore these, okay? So these are sort of waiting in the wings, for want of a better word. Okay, so now here's another little thing that we do, and this is straight from the practice, so it's not just a sort of, it's not an academic discussion, this is photographs of what I've done in my practice. I found it very difficult years ago to explain to patients that if we build the lower anteriors up, then the posteriors are no longer in contact. So you've got to do at least the whole arch. You can try and talk about over-eruption and weight. Sometimes it happens, sometimes it doesn't. And so what I've done is I've got to, forget all that, I've got a set of study models like that, mounted them on a semi-adjustable articulator. There they are there, and they've got a bit of tooth wear, and I say to Mr. Jones, this is a bit like you, okay? So I got these, and what we've done is we've waxed these up, okay? So we've waxed the anteriors up and left the upper posteriors as is, okay? And I keep these as demo models. So we've gone from that to that, and I've got them to over-wax and exaggerate so that, I wouldn't do as much on here in real life. We've waxed the back of these and the length of these. There's the thing there, and we've only waxed the front. So we can show this to the patient. So look, when you make these bigger, they don't touch. And I'll use these probably once every 2 weeks with a new patient, saying, look, so it's like the legs of a table. You've got 6 legs, you make 2 legs longer, the other 4 ain't going to touch the ground. So this helps me try and explain to the patient that, you've got to do at least 1 arch. You can't just do the anteriors, simple as that. And if you want to spend, I don't know what they cost anymore, we've got a lab, and this has been there for years, but I'm sort of thinking if you did this with a lab, it might cost you $200 or $300, maybe more in terms of study models, and we get the articulator, grab it out and put it on the articulator, and it's one of the best things you can show in terms of trying to explain to patients, because you understand it, I promise you they don't, okay? So you've got to do all at the same time. There's the implication also in terms of money. If I'm restoring this case and I say, I don't quote for, say, well, let's say we're doing lower anteriors as well, which I rarely do. Let's say we're quoting for 12 crowns. I don't quote for 12 crowns. I quote for 12 plus, say, 16 or 14 at the back. So I'll quote for 28 crowns or 24 crowns. And we have a payment scheme, and they pay sort of 25% lots. And they don't pay 25% of the front, they pay 25% of the whole lot. So they're committed to going to doing the back ones. If they don't, or they only pay that front part, because sometimes that happens as well. You know, people always slip under the radar. And they do that and then don't get the back done. I've had one or two of those over the years, because we've had lots of these sort of cases. They don't do the back, well, it's on their head kind of thing, you know. So you can't just do that and leave those like that. So you've got to work out the money implications, and you've got to do them at the same time, because a lot of patients will say, well, can we just do the front? The answer is no, you can't. And I lose an unhealthy number of patients that I say that to, because they only want the front done, and the front is so worn that you can't restore the front unless you open the vertical. And if you open the vertical, you've got to do a full arch, and crown lengthening won't get you there because it's worn at the back. So if the front teeth are worn so much that if you do any more prepping on those, you're going to hit the pulp. You don't really want to do that. So if the front teeth are worn that much, you've got to open the vertical. You've got to make them longer, maybe thicker at the back, depends on the occlusion. So then you've got to do the back. And they only want the front. I say, well, I can't help you. And like I said, you can't help everyone. And the big thing is you don't need to reduce the occlusal or incisal reduction, if at all, because you've achieved the space by opening the vertical. So that's what we tell patients. If we tell them that they're going to, see, this is the case I remember, this is Steve the electrician, and what happens is we built these up years ago, he sort of chipped a few, and eventually these have worn down. He's got an implant there somewhere, and basically these are worn at the point where he started chipping them and losing the composite, and he just wanted another one. And it got to the point where you were down to tooth structure, and the tooth structure of the lower was in contact with the palatal of the uppers. You couldn't do another one. So then you may or may not need crowns. I told you about the eruption, and the other big thing is that most of these guys end up with some sort of splint, for obvious reasons. By the way, if you've got any questions, just don't hesitate. I have no idea how we're going for time. So in terms of mandibular incisors, if I can leave them smooth, I will, or just fill in the cupping, or add some composite. Otherwise, you sort of move on and start talking of porcelain veneers or raw ceramic crowns. Like I said, I don't do much crown lengthening. Used to, got a lot of slides on it, didn't put them in for time. We've done quite a few cases with veneers, e.g. that one. Now, whether we go over the incisal edge or not, we'll come to in a sec. And again, I don't do a lot of veneers for mandibular anteriors, but I do some. We'll talk a bit more about veneers. The problem with veneers is that they have, they're a fantastic restoration, and a lot of guys stand up saying, oh, it's my favourite, get some fantastic results. There's no question about that. The problem is, with their limitation, they're not very good with parafunction. This guy was in the special forces in the army, and the army dentists kept making veneers, and every time one came off, they'd do that one, then that one came off, they'd do that one, and that one came off. The other thing is you need to have them mostly in enamel for the margins. You've got to have a good underlying colour. If you don't have a good underlying colour, you're going to have to make it thick, or you're going to make it very opaque. The bottom line is, and they're also only really good for sort of minor corrections, and they're very difficult if you've got extensive composites like class 3 and class 4. So, all these limitations come into play. So what that means in my book is that, they're only good for cases that don't need a lot of, large problems. And if they don't have large problems, I start asking myself, well, why are we doing veneers at all? So I tend to sort of go a little, now I'll show you some veneers in a sec. I certainly do a healthy number, but the situation is we tend to sort of say, well, you don't really need a veneer, or you need to go to the next step, which is the crown. And so quite often I'll come in for veneers and I say, look, you got all these, or some of these problems, and I'm not doing veneers. If you want me, I'm doing crowns. And sometimes I lose the patient. But then if you do veneers, you get this sort of problem. So the other option was just finishing the lower scenario, is these sort of cases, that patient comes in for veneers, they're worn, they've got lots of dentine, you've got the vertical dimension like that, And so, you know, in my book, they're not veneers, they're crowns. That's the deciduous canine. We're going to take that out. This is the sort of case we'll show you a bit more of. So we're taking that tooth out. We do our U sort of wax up, and they're getting implants one side, bridge work on the other, and crowns on the mandibulars. Okay, so that's what I was saying before. That deciduous tube's gone, so we're going to do a bridge there, not an implant, because they're getting crowned anyway in this case. We've got healing abutments at the back, waiting for those to be ready to be restored. We've got our crown preps there, and then so we do our crown preps there, and then as soon as we bridge there, as soon as we place those, we get straight on to doing the back. Now you could do it all as one arch and do one impression, and that's fine. It's not what I do usually. I'll show you what in a minute. So I'm restoring the anteriors. I'm doing a bridge there, so do that bit. There we'll either leave it because we're doing a bridge there. I know it's tilted, we'll show that in a minute, or an implant's there. So my standard kind of preferred protocol is we'll do the anteriors first, mandibular before maxillary, or both together, then the posteriors in what we call opposing quadrants, top and bottom, at the same time, because then they match each other. So there it is, sort of almost finished up. So we've got a bunch of crowns there, bridge there, new bridge there, implants there. So we got that. And, you know, I'll talk about the health. One of the things I'll talk about later is soft tissue management. So there's, now we haven't increased, if you have a look carefully, that's gone up maybe a couple of mil, maybe 3 at most. You have a look at how much is showing there versus that. And in this case, we did the lower because that's what was needed, if you like. And we're going to do the upper in due course. Now, I'm not worried if she never does the upper because we've got one arch restored, we've got the vertical, we've got a good spread of even occlusal contact all the way around the arch. Just another case. What we're doing is we've got some old crowns and bridge work. This is loose and she doesn't like the colour anymore. And so we're going to redo that. Now, one of the, you know, this is sort of a catch cry. I'm sure most of you guys, well, I think most of you guys know this. You know, not many of us use root-filled teeth as bridge abutments, particularly sort of longer ones with free pontics. You know, their prognosis of using that tooth as a bridge abutment is very poor. So we're going to replace these 3 pontics with implants. We're going to replace these other crowns because we are. So the question is, what do we do with this tooth? Is it going to stay with it? It could stay as an individual post-core crown because it's got a much better prognosis there. But if I'm already doing implants next to it, I would say more times than not, I'll remove this and make it part of the implant scenario. Even though it's had an apicectomy, it's got not much coronal tooth structure. You know, if that was on its own and all the other teeth were there, I have no problem retaining that. But if you're going to do implants next to that, then most times in that case, that's going to be extracted. So we're going to extract that. So now we've got, again, we've put the implants in first. There's 2 implants that are going to hold 3 or 4 teeth, whatever it is. We'll see in a minute. We don't touch these to make sure these are integrated. Otherwise, you know, you're going to have egg on your face. And the other thing is, there's the sort of finished product. One of the 2 things, I don't like root-filled teeth as bridge abutments. The other thing I'd show you is, I don't, you know, I've had this conversation, I used to have it with our technician, and we sort of wised him up. When you look at the colour, now if you're doing an upper lateral, okay, what the technician will often do is try and look at the lateral on the other side, the contralateral, and they'll try and make it sort of similar shape and colour to that. And eventually, the patients don't like that. If you've got an upper lateral on the other side that you're going to try and match, and that lateral is sort of, you know, class 2 div 1 where it's sort of poking out or rotated, so then they make the other one that's going to replace as, you know, out and rotated. Patients don't like that. I've got stage where I don't like it. You look at the teeth around where it is rather than the teeth further away from it. And the same with colour. With the colour, they look at sort of not the opposing arch and not the other side, but the teeth in that quadrant or the teeth either side. And then if you've got a shape and colour that matches the teeth either side, then it's continuous, both in shape and colour. So, you know, when we take the shade, almost sort of, the technician comes in, we sort of almost ignore that and look more in the lower arch. She was in the other day, and that's a 10-year post-op. You can see margins have gone down a bit of staining, but that's not too bad. And that's the vertical, which is probably closed back a bit, see? Oh, she's open there. Oh, that's before, that's after. So this is what I just started saying in terms of, like I say, giving you a bit of advice. We're doing an implant here, could be a bridge, either way. We don't match that tooth, okay? Patients don't like it. I used to get them back like that. We just do it sort of more ideal. Yes, the gingiva's up a bit, but that'll be up wherever we put the tooth, but that is matching or blending with those teeth, not that one, yeah? And just, so we're looking at stuff, the eye looks at what's around it, not what's further away from it, okay? Now, I'm sorry that it's blurred, but it's off the internet. It's a sort of test. Put your hand up about which one of these is longer or bigger, larger, call it what you will. Okay, so who thinks the brown shape's bigger? No one. Okay, pretty obvious. Who thinks this purple shape's bigger? Who's not looking? Okay, so most people agree that the purple's bigger, correct? Yeah? Say yeah. No, okay. So now which one's bigger? The brown. Holy crap. In actual fact, they're the same size. You just Google optical illusions, you'll find 20 of these things. What happens is your eye is looking at the things closest. They're looking at the long edge of this purple one against the short edge of the brown one. And vice versa, the long edge of the brown one versus the short edge of the purple one, maroon one. When you put them together, they're the same. So your eye looking at this lateral is not looking at the lateral on the other side. You might be, the technician might be, but the patient isn't. It's right there. So that's why we do that. That's what I do that. You guys do whatever you reckon. Here's an interesting case in terms of space. The problem is the lateral is just about as big as the central, and they don't look really nice. And you sort of think, well, sort of golden proportions, and that should be 2/3 of that. The height-width ratio is like less than ideal. And the question is, we're going to put new crowns. You can only make them as big as what the space is. And here's an interesting one with space problems. This guy's got two fused teeth there. Some of you might have seen this before. And someone's made two posts. This was done in Holland. And they put two nice posts in, and the crown there, they tried to make it look like two teeth. It looks pretty good. And so they put a line down here, and there's a lateral there. They should have switched it the other way. And this guy's seen about 10 or 15 dentists. And everyone said, I don't know what to do. No one touched him. So they saw us, and I said, I don't know what to do. So basically, we came up with, well, we removed this. Actually, I should have shown the crown prep. And it was okay. So what we did was take the crown off, and there's the original prep is on a model, and I did a great big groove down here. And instead of going essentially what they tried to do as a central lateral, but in reverse, I mean, that's meant to be. We're going to decide we're going to do a central lateral in the correct order with a bit of pink. And we've ended up with that, from that. It's a matter of visualising, so you can see what you can do. So they're splintered. Well, it's really one crown with a bit of pink papilla, and the guy was very happy. This one was another interesting one where this was done overseas, and the patient was missing two teeth, so she was going to get two teeth. And so they had two teeth, and there it was. So that's the first part.